This is breakout 1 on evidence with Joy Lawn on COVID-19 and the impact on the health of women, children, and adolescents. I'll just give it a couple minutes while people continue to stream in. We've got about 75 participants. A couple more trickling in. Okay, so let's get started. My name is Annika Patel. I'm from The Difference. I'll be facilitating today's breakout with you all, with Joy Lawn. Joy is the professor of the London School of Hygiene and Tropical Medicine. She's here to shed some light and experience and her expertise on this important topic, and mainly the disruption of COVID-19 on the sexual, reproductive, maternal, newborn, child and adolescent health services, and what that means in terms of the impact on women, children and adolescents. She's also going to take a look at how evidence can play a role in responding to the needs of women, children and adolescents, and how research is constantly evolving in real time. So we were also meant to be joined by Queen Dube, who is the head of pediatrics down on the front lines in Malawi. She's actually on call, so couldn't join us today, but is a good friend and colleague of Joy. So I'm sure Joy can speak on her behalf in terms of what is happening right now. So before we jump to Joy and I invite her to speak, just a couple housekeeping mentions is that you are all on mute for this portion while Joy speaks, but you are more than welcome to chat in any questions, comments as she's talking, and there'll be an opportunity for all of us to have a larger discussion toward the end of the 40 minutes together. So before I kick it off to Joy, just a quick poll, actually a quick quiz to see where the numbers fall. So I'll get our tech to bring that up. And the question is, how many deaths have there been so far from COVID-19 worldwide in 2020? Okay, so results are in. I'll just share that with you all. So it is actually 500,000. We had some estimating over 1 million, some for 1 million. It's actually 500,000. Now I want to share another question just to tee up where Joy is going to be, what Joy will be speaking on, and that is how many deaths of women, children, adolescents and stillbirths worldwide in 2019. Just select your response there. Okay. Results are tracking in, people still deciding, and so still in progress. Okay. All right. So there are the poll results. I'll hand it over to Joy to speak more to this. Over to you, Joy. Just unmute and you're good to go.
Good afternoon, good morning, good evening, everybody. It's such a pleasure to be here, but also really sad that I'm here without Queen. So Queen, as many of you will know, is a dynamic champion for women, children, newborns, but she is in the neonatal unit and the pediatric unit in Malawi, and 3 of her colleagues unfortunately are either infected or in quarantine, and she just wasn't able to join. So she sends deep apologies, and also that you would be thinking of her. So, you know, we're sending her energy. She's a leader on the front, and that's actually what this is about, that COVID is a disruptor even for global summits. So interestingly, for a group of evidence people, you were fantastic on the COVID data. Maybe you've got good short-term memory. So I think several people in the opening session underlined that we're at around 500,000 deaths. This is shocking, more than 10 million confirmed cases. And in many cases, we focus on the deaths. the bad part. But COVID is also a disruptor of the science. So if you looked at PubMed this morning and you did a search for COVID, there are 26,000 publications, most of them in the 110 days since this became a pandemic. And that's huge. It's a deluge of science and maybe some pseudoscience. Happily, 68% of them are open access. So it's really disrupted the science. It's going faster, more of it's open access. And that's driven not just by scientists pushing it out, but by demand. You know, we don't always see this demand for science on women's and children's health. People want science on COVID, partly because of the fear factor. But there's also solutions, more than 100 vaccines already in development. That's unbelievable. The pace for vaccine science development is going about 10-fold faster than normal. But in the midst of that, there's also risks. There are some papers that have had to be retracted. There are some things maybe that aren't, that are evidence-based. And most of that science, almost all of those 26,000 papers are focused on the disease. The epidemiology, which we know this is the most ageist virus ever, unfortunately, really targets the vulnerable elderly. So most other viruses also target the vulnerable very young. So there are surprising things that we're still learning and understanding. But in that disease-centered focus, the pivot that this summit wants to see is to move to a people-centered focus, and particularly for those who are most vulnerable, women, newborns, and children and adolescents. And in the poll that we just did now for an evidence-based group who advocate for women's and children's health, it's actually surprising that people were off track on what the answer was. So most of you said a total of 1 million deaths. In fact, there are 2.8 million children after the first month of life, 2.5 million newborns, 2.6 million stillbirths, 0.3 million maternal deaths, and about 0.8 million adolescents who die every year. So in fact, there are already 9 million deaths every year for women and children, about 50% related to pregnancy and birth. But we obviously seem to be failing to get those numbers out, if even amongst our own communities, so the evidence-based group of PMNCH, we don't have that in our head. And at the beginning of 2020, our focus was on the urgency for this. 10 years to go to the Sustainable Development Goals, and these are just the survive ones. The global strategy also looks at Thrive, a much bigger agenda. And some of these outcomes are still not even on the agenda. So in the disruption from COVID, what's happening? Are these deaths going more off track? Are we going to lose hard-won gains? Will this threaten where we are for the Sustainable Development Goals 10 years from now? Well, most of the data that's being published is about the direct effect. What's the risk that the SARS-CoV-2 virus poses for women, for newborns, children, and adolescents? And we know that women are definitely at lower risk than men, that the age group of women of reproductive age have less risk of severe disease, that some pregnant women are more vulnerable. But we also have data gaps, poor data that has been collected on stillbirths, on some of the pregnancy outcomes, apparently low risk for newborns, but very low data. Pretty sure that we have a low risk of severe disease in children, but there is this rare new important syndrome, and a low risk in adolescents. So as Helen Clark particularly underlined in the plenary, and also Dr. Tedros, it's likely that the indirect effects are going to be vastly higher than the direct effects, especially for the most vulnerable. And that is what this summit is about. And so what are our ways, our strategies, our evidence base for protecting services? Well, PMNCH promotes evidence-based care through the continuum. Sexual health services, care during pregnancy for women, newborn care, effective care for children, and also for adolescents. And that's split by outpatient and inpatient services. but also importantly, intersectoral and social protection. So these are the things that PMNCH has stood for since it started, and that for us in evidence base, we know that there are impact for them. But what do we know about what's happening to these services now? Well, if we look at what we know in the published literature from previous epidemics, for example, Ebola in West Africa, there was reductions in outpatient services, but actually more reductions for inpatient services. So the way that those epidemics worked, and whether that was in vulnerable countries with weaker health systems in West Africa or in Southeast Asia with apparently stronger systems, there was a very big effect on services. But when did we get that data? Well, most of those papers were not published till maybe 2 years after. So here we are now in the middle, and the result of that is not just the reduced services, but deaths, maternal deaths and stillbirths increased, especially with reduced inpatient care. So here we are now in the COVID epidemic. What do we know about services? Well, WHO do a very important essential health services survey in 89 countries. And amongst those 89 countries in the last round, more than 50% of the respondents from countries said there was moderate to severe disruption for outpatient services, so more than for inpatient services. About 30% reported moderate or severe disruption for things like care at birth and sick child care. So it looks like for COVID, with the way the pandemic lockdown has worked, that particularly outpatient services, family planning, immunization and so on have been affected. But we want to underline that these data are based on surveys of perceptions. There are several really important modelling exercises, particularly on sexual and reproductive health effects, which have been led by UNFPA and colleagues, and then also on maternal and child deaths with a Lives Saved modelling exercise. But we have a lack of primary data, and most of the modelling exercises have focused on one part of the continuum of care. We don't have a consistent examination of what's happening across the continuum for women, children, and adolescents. Importantly, WHO and UNICEF are leading coordinated work on this, and congratulations to Teresa Diaz and others who are leading that. So to finish up with, what's the pivot we want to see? So we're seeing a huge problem with the disease. We're seeing a large deluge of science. But how do we move forward to make this people-centered solutions? We need more primary data on what's actually happening in countries, not just perceptions or modeling. We need to include all the relevant outcomes, and then we need to turn that into solutions, not just admiring the problem, but finding a way forward. Protect services now, work out how to build back better, share between ourselves, and that's what this session is about. And I want to end with a challenge which Queen asked me to pass on. This pandemic is a test of leadership, and we can point at our politicians, but it's also a test of leadership for each of us. What are each of us doing in our work and in our daily lives to protect women, children, and to use the evidence? Thank you very much.
Thank you, Joy. We're going to now, I'd actually encourage you to switch your videos back on. We're going to move into an interactive portion for you guys to actually connect with one another in smaller groups for a few minutes, just to reflect on what Joy mentioned there. And I'd like you all to just reflect on the question, what was most thought-provoking? What did you find interesting? And potentially any solutions that you see useful as a way forward using all this data. So for you, what was most thought-provoking about this presentation? About 7 minutes to do this. A couple housekeeping things. It's unfacilitated, so there won't be anyone in there when you emerge in your breakout to tell you what to do. So you might want to take a picture of this screen or just remember the question. unmute yourselves, turn your cameras on, and continue to chat in to the conversation. When we return, we'll carry on with the discussion. Okay, so you're about to be zoomed out into your breakouts. Enjoy. Okay, welcome back from Zoom time travel, everyone. Waiting for people to just re-emerge. Welcome back, welcome back. Here they come. We're up to 76 participants in this group. Wow. So I hope you all managed to have a great conversation, just sharing your quick reflections on some of the data and information Joy provided. For the next 10-ish minutes, we're going to continue the conversation with Joy. So you still will remain on mute, but please chat in your questions or comments, anything that came up, into the live chat on the bottom toolbar. And we will feed those questions to Joy. I think one question straight off the bat, Joy, that was mentioned was around evidence and data that's emerging, and the critical role in understanding what works and how to mitigate the impacts of pandemics. How is COVID acting as a game changer for research and evidence generation and use?
Yes, thank you very much. I mean, I think looking at the impact and learning how to mitigate, we need two big different types of data. One is the numbers, and then the second is the learnings. And at the moment, you know, we still don't have the numbers. So we've got numbers for lots of other things, but actually for service disruption, health service disruption, and especially social service disruption, we don't have the numbers. So we need to do better on that, not just modeling, not just people's perceptions. And then we need to do that more quickly as well. So after the last pandemics, it was maybe 2 years afterwards that people published data. That's not good enough. We need to do what everything else is doing for the COVID science. We need to be quicker with the data. And then the second thing, and I think this is where it'd be great to hear from people, is how do we do better at learning? So those kind of qualitative stories, putting them together, resilience, what's working. It'd be lovely to hear from people here. How can we do better on that?
Yeah, so just a reminder, you can chat in any thoughts you have on that, solutions, how we do better. Just use the live chat feature below. There was another question, Joy, around the muddling of data, which you touched on. And so how we respond quickly and in real time without getting our knickers in a knot, so to speak, with the data. What are your thoughts on how we do that?
Well, I see many friends on this list, and for people who are part of, you know, peer review journals and the submission process, I mean, an average peer review journal process can be a year. That's what we're seeing in COVID is the fast track ones, you know, sometimes even the journals put them out and say they aren't reviewed. So at the London School, we're instituting an internal review before, for example, modelled papers go out, to make sure that other people have peer reviewed them within an institution. So I think it's good in terms of transparency and speed, and, you know, speed is lives at the moment. I think it does have risks, and it would also be good to hear from people on that. And then the other thing, I think we often focus on the supply side, so the supply of science. What has changed here is the demand for science is different. And we need also to have demand for science for women's and children's health. Everybody knew that 500,000 deaths from COVID had happened. Almost none of this audience knew we have 9 million deaths every year. I mean, we don't even know our own evidence. So we also need more demand for evidence about women's and children's health.
Yeah. Thanks, Joy. Another question that's come in is, of the countries and states that are doing well with respect to controlling the number of cases, do we know if the health infrastructure, so outpatient, inpatient, is better adapted there? Or did we learn this from the Ebola SARS data?
Well, we only have a few studies from Ebola, And we know that in West Africa, you know, already, for example, before Ebola, Sierra Leone had the highest maternal mortality ratio in the world, which is a very strong reflector of the state of the health system prior to this. I think it also depends on the response of leaders. So the response of leaders can really be a game changer, not just in terms of how services are protected, how do we innovate to keep immunization, family planning, outpatient services going, how do we make sure that we provide essential inpatient services, and that's also about addressing fear, the fear of the workers. You know, do nurses, do doctors, do midwives have PPE that they need? And because if they don't, they'll go on strike. We've seen that in some African countries. And then also fear of people coming. So families will not come to hospitals if they think they're going to get a virus. So it'd be very interesting to hear from people here, you know, what do they think are the ways that essential services can be protected?
Thanks, Joy. It looks like people are commenting in that some solutions might be expansion of partnerships and working relationships with community-based trusted partners that are more connected to communities with high burdens of disease and death. So you're nodding as that's a good solution to that. So how do we use some of this evidence to better engage with our communities?
Well, I think there's evidence we have from before too. So we know that, you know, women will not come for care at birth if they have experienced disrespect and abuse in a previous pregnancy episode. And it's actually maybe more scary now. So both the health worker and the, you know, the woman or the adolescent or the child will be more scared. So I think addressing fear and thinking about how we do that, both for workers and for populations. And I think that takes all things, both the grassroots with community groups, but it also takes leadership from the top. It also takes the media has a very important role to play. And within science, how do we communicate that? Because we need to communicate facts and things that are concerning to people. But if we turn that into a way that frightens everybody, then it may be counterproductive.
Another question coming in around with the information that pregnant women are at higher risk, what can we do to ensure that providers are well equipped and knowledgeable to prevent patient neglect? And what should leaders do? This is from the Midwives Association of Zambia. Thank you.
Thank you. Thank you. And I also see that the president of ICM, Franca, is on this group. Yeah, I mean, I think actually for direct infection with SARS-CoV-2, women of reproductive age are not the highest risk group. You know, women are at lower risk, and that age of women are overall not at the highest risk. But there are certain subpopulations of pregnant women who are at higher risk of severe disease, and that's a major risk for them and also for their babies. So, you know, we're seeing probably risks of higher risk of preterm birth and other outcomes. So in terms of that, I think WHO has fantastic guidance. I would encourage everybody to look at that. PMNCH is doing a mapping of guidance. If you have useful materials, please share them with PMNCH. I think one of the challenges is the guidance changes all the time. So I had a chat with Queen and she was highlighting this. You know, 1 week you have one guideline and 2 weeks later it seems different. So that, I mean, that's challenging for people, you know. How do we get that out to people? There are examples of, for example, WhatsApp groups of midwives associations where you can push out guidelines more quickly. In Kenya, there's fantastic examples of doing webinars, which the Kenya Pediatric Association has been running with others. So I think sharing these ideas, because it's also the deluge of information and the speed of change is challenging for practice, I think. It increases stress for workers as well.
Great. I want to switch to technology. There's some questions coming in around that with the use of technology and working with ministries of health, sharing information and with their convening mechanisms, if you're an academic doing a study, it's so critical to share preliminary results with MOH for inputs and knowledge translation for improving implementation. But this also means that MOH need to be open to learning from academics and partners, a true test of leadership. It's a comment that's come in there.
And maybe that reflects back to Helen Clark's poll on leadership. So I think when people were answering that, they were maybe thinking of political leadership, but whether it's Ministry of Health leadership or academic leadership, I would highlight that the word that came out biggest was humility. And I think that if we are data scientists, we always need to stay humble, because the data we have in front of us will have gaps. Our data is never perfect. Nobody else's data is perfect. And I love the saying from Lord Box, all models are wrong, but some are useful. So I think humility, because that's the way to learn. If we think we're right, you know, many of the things that people thought were right about this virus at the beginning have actually been proven wrong. So I think humility is critical on all fronts.
Thanks. And so questions around lower middle income countries. How can we support them to efficiently use technology to collect quality data during this lockdown?
Yeah, thanks. I think this comes back to the question of preparedness. So countries that already had a good health information system are in a better position. So many low and middle income countries have electronic health information systems, particularly with DHIS2. There are a few of them. I understand Nigeria has used their national data to put out a summary of status and change for health services. I think the challenge is if your system already had gaps before this epidemic, it may have more gaps after. So I think this is also on the build better point. You know, we will have more epidemics. We will have more that affect essential services. Essential services, especially for women and children's health, probably the quality gap for essential services, you know, needs data to drive it. So we need to make the critical point to have routine, strong data systems and being able to improve those between pandemics, because then we'll be able both to detect better, but also protect better.
Some questions, Joy, coming in around community health workers. So they're poised to help maintain access to essential health services during COVID, as well as help prevent, detect, and respond to the virus. What are some ideas for protecting and supporting the well-being of those community health workers and their supervisors during this pandemic?
Yeah, there was some interesting information from India last week. So around 1 million, mainly women, community health workers who are really going to be at the front end of the COVID response in communities. And I think very few of them have personal protective equipment. So I think community health workers are essential. And that's really a very important arm of trust within communities. So in Sierra Leone and Liberia during the Ebola outbreak, actually community health workers were really fundamentally critical for community trust. But if we're asking community health workers to do that, then we also have a responsibility to make sure they too are protected and informed as well. So how do we do that? You know, is it WhatsApp groups is what's used a lot in India, but it would be interesting to hear from people.
It looks like some of the comments, Joy, are around using social media to aggressively share data, and also particularly around making the newborn count, but also the dangers of social media and how that can be used for good or for evil. So other comments that people have around how we do this, but any comments to that, Joy, on using social media?
I think there's major learning in the science from the vaccine confidence movement. So during the early days, there was no response to what was posted on social media about vaccines and vaccine confidence. And what has been learnt, there's a group at Dillon School who work on this full time, is you actually need to pick rumours early and respond to them. So your social media strategy shouldn't just be reactive long after something is out there. You have to have proactive, positive messaging and early detection of rumours and response. And there's a science to that I think we haven't invested enough in. And it's another reflection of pandemic preparedness. So, COVID gives us an opportunity to put this up a higher scale. So then, how do we do that to then put out more positive messages about care at birth, vulnerable babies, for adolescents, for gender-based violence, for sexual and reproductive health? We need to be much more scientific. It shouldn't just be noise. We actually need to get it right.
Right, so we've got a comment that's come in around 1 out of 5 women in the world has a disability, but still disability disaggregated on MNCH. They're very limited. This didn't change during the COVID-19 pandemic, so the challenges and barriers women with disabilities face are not identified, and this limits our capacity to fully meet their needs. This cannot be overlooked if we really want to ensure that no one is left behind. So in response to that, I think another question is, how do we bring those into rural settings? So community workers and birth attendants, there's so many in Sierra Leone have been affected by the lockdown.
Yes, I think there are 2 things there. So one is about disability, and this is critical, the invisibility of disability, both in social circles, but also in the data, perpetuates the vulnerability. And it comes back to, what our data do before the pandemic, because, but building the plane or the fire engine while your house is on fire is not the way to go. So how do we do better about measuring disability for women, for children, for adolescents? How do we do better at preventing it? And how do we look for other vulnerable groups as well? So if our data are weak in splitting by gender, by ethnic group. So one of the big things that's come out of COVID, which is so important, is how weak we've been at splitting out different ethnicity groups that are at risk, and how important that is for social justice. So in building back better, we need to build that into our data systems much more. And the urban-rural divide, often in low and middle income countries, the rural data systems are weaker. So we need to really look at that carefully for this leaving no one behind data.
Thanks. We've just got a few more minutes left to continue this discussion before we return back to plenary. We've touched on this before, Joy, but there is a lot of commentary on how do you explain that so few of us knew that the 9 million deaths in women, children and adolescents was occurring. We're overwhelmed by the COVID numbers. So what can PMNCH do to really amplify this, the 9 million?
Well, I think that's a challenge to PMNCH, because this is your core message. There are almost 9 million women, children, adolescents dying every year, and our own constituents don't know that. It can't be clear enough in your messaging. I actually think some of it is because in advocacy we follow politics, and politics feels that the death agenda finished in the Millennium Development Goal era. It's not correct. And I think a particular blind spot is in the stillbirths. So around 1/3 of those almost are stillbirths, so people don't count those. But if you were listening to women and families, absolutely count them. I mean, there's the stigma after stillbirth. And I'm sure that the midwives here can speak to that, and also it's traumatic for the midwife. So, these are deaths that do count, and we need to count them. And I think the challenge is, I throw it back to PMNCH. If our core constituencies don't know this number, there's something wrong with our messaging.
So I'll leave it on this final question. Joy, what advice do you have to bring more evidence in solutions and policy, financing and service delivery for women, children and adolescents?
Well, that's a big question. I think critical that we join up, because a part of the strength of PMNCH is we stand not just for one corner. So, you know, looking at the chat, there are beautiful people who have advocated for really important issues. But if we want to be heard in the midst of the noise of the COVID pandemic, we need to join up our voice for women, children, adolescents and newborns. And we really need to make that voice count. That's absolutely critical. And we need to make it not just with noise, we need to take out that 9 million deaths and do something about it and use the evidence to protect those most vulnerable women, children, adolescents, and newborns.
Okay, well, we'll leave it there. Thank you very much, Joy, for your time. There's a lot of appreciation and love coming through for you on the live chat. We will now be returning back to plenary. There's some yoga happening, so you can join that. You'll need to use the link. We'll put it in the chat for you. It's also there on the screen for you to go to via YouTube. So just click back to that link and this breakout will end shortly, and we'll continue on with the other conversations. Thank you for joining, and thank you to Joy.
Thank you, everybody, and also thank you, Annika.